Thank you very much. I appreciate that nice introduction. I want to tell you where this title came from. So this came from my reaction to last year's meeting where excellent, wonderful science, but from my point of view, was telling a part of a story of an older adult and their body composition. I was thinking, what about fat? And then I've come to this meeting, and there's lots, Dr. Goodpaster, and lots of information about fatty infiltration. So even in a year's time, there's been quite an evolution, at least from my perspective in the field. I have no relevant disclosures. Here's what I'd like to talk with you about. Briefly, just review very quickly obesity's contribution to mobility function and frailty, and really talk about this from an interventionist perspective. What happens when we intervene in obese older people to the dimensions of sarcopenia and frailty? And finally, are there ways we can maximize the benefits of weight loss for older adults in a way to help preserve muscle mass and hopefully improve function? This is the prevalence of obesity in older adults by years, both chronologic age, but also by age epoch for up through 2000. The latest data I've seen suggests that the prevalence of obesity in older adults has stabilized at about 40% of people over 65 are obese, and even more are overweight. So it's a very common problem, at least in the United States, in older folks. And it's really important in the long-term health span of older adults. These are data from the Women's Health Initiative observational study, and you can see the odds ratios for various entities that I'll discuss in a minute by several BMI categories compared to the 18.5 to less than 25 BMI category, the so-called desirable weight category. And if you look at, this analysis is basically taking everyone at entry and seeing what happened to them by age 85 as a function of their BMI when they entered the study. And what you can see for mobility, disability in the middle, that any amount of obesity, class 1, class 2 plus, are greatly associated with mobility impairments in older women. If you look at the survival, the intermediate weight women seem to do there's a large flat piece of the distribution, but more severe levels of obesity and being underweight are related to increased levels of increased mortality risk. And then on the left side, this is the new onset of new diseases as a function of weight. And being obese is certainly, especially the more severe levels of obesity, is clearly related to that. So you have 36,000 women, you don't really have to have p-values, because basically anything they find is pretty much highly statistically significant. So fat has a very important role in the disability process. I mean, especially excess fat. People who are very obese have a change in gait mechanics, and that is related to a worse efficiency in walking. Very common complaint in older folks who are overweight are pain in the lower extremities, hip, knee, and foot pain. This pain is the #1 attributable symptom to why people say they have difficulty walking. If they say they have difficulty, you ask them why. Pain, lower extremity pain, is most frequently endorsed reason. Older people who are obese have to work harder to move themselves around. They have a decreased power to weight ratio, so they might be using a very high proportion of their 1 RM max to get out of a chair or do things that a thinner person would have to exert much less relative effort for. Obesity certainly contributes to many age-related comorbidities that are disabling in themselves. And fat mass is highly correlated, or it's correlated robustly in study after study with IL-6 and other cytokine levels. So that's just at the whole body level. Our center has done a lot of imaging of where fat in the body is, and what we find is that fat is bad for whatever it's near. So some people have an excess of pericardial fat, which is associated with increased rates of atherosclerosis. Leg fat, as we've heard many times in this conference, is associated with impaired function. It's also associated with insulin resistance. It's also associated with hypercytokinin. There's some thought that in very obese people, the abdominal fat may actually mechanically interfere with things like breathing and diaphragm expansion. In older animals, older mice, the fat mass is seems to collect senescent cells, and this cell type is noted for the secretion of something called a senescence-associated secretory phenotype, which is a very a milieu or a soup of inflammatory, pro-inflammatory factors that, at least in mice, if you can eradicate or knock down the number of senescent cells, mobility function and frailty appearing symptoms actually resolve in older mice. And at the cell level, and if you saw Dr. Goodpaster's speech yesterday, he showed something from one of our labs at Wake that obesity in older adults is associated with actual changes to the individual muscle fiber ability to exert force. So there's a lot of reasons to be concerned about adiposity and fat and its geography in the body and the relationship to function. So when we're trying to look at obesity and sarcopenia together, at least I end up scratching my head a lot, because a lot of who you say is obese and sarcopenic depends very much on which definitions of sarcopenia and obesity you use. And I'm not going to go into this in great detail, but this study illustrates the point very well. These are looking at NHANES nationally representative data, and I've just extracted the 70 to 79-year-olds out of this. You have men and women, and you have the two FNIH criteria that were published last year, and then obesity defined either as from BMI basis or on percent body fat through DEXA. And you can see if, depending on how you do it, for example, over here, if you use the raw appendicular lean mass for a man and BMI over 30, they don't exist. There are very few people. Though if you use other definitions, it can become much more common. And then if you look at the conditional, which is among sarcopenia, how many people are actually obese, this follows on that if you use this BMI adjusted appendicular lean mass and this body composition grade, they're virtually all obese, or very few are obese. So it's a very definitionally has proven to be something of a challenge. But I don't think it should distract us from the understanding that in both our desire to classify sarcopenia or frailty and obesity is always because of the functional impact on the person. If we don't lose sight, if we can keep that in sight, I think we're going to be doing well. This is showing the association between body mass index and prevalent and incident frailty in the Women's Health Initiative. You can see underweight women have both more frailty at baseline compared to the normal weight women with a very great elevation in the odds of incidence. And then people with BMIs over 30 or the cut point of obesity, also a high prevalence of frailty and a very high odds incidence of developing frailty over the next several years. So clearly obesity and frailty are closely linked to each other. So if you have a functionally impaired person who is obese and maybe showing signs of frailty, should you or should you not intervene on the obesity? And this has actually been a fraught question, and there are really two views of this. There's a sarcopenia view, which comes from a muscle mass tradition in its definition, that any loss of total mass will include a loss of lean mass and fat mass and bone density, and maybe you're putting people worse off if you're causing people to lose lean mass. In addition, one of the most common clinical observations, I'd say common, but really most replicable, is that older people who are losing weight for no particular reason that you can identify are very likely to have a very major health event follow on very soon and are much more likely to die. There's an obesity view of this, though. If you look at the obesity guidelines, they don't really talk about age much, and they think you should go do it because of all the other benefits of weight loss in younger people should also obtain to older people. So our center has been looking at weight loss in people generally over the age of 70 to 79, but in also a somewhat wider age range than that, to quantify and look at the trade-off between the sarcopenia view and the obesity view. Some background on this: we know that in older people that weight loss and exercise together was very effective in the prevention of diabetes in at-risk older adults, more so than the drugs in that study. It's been shown in older adults that diet-induced weight loss reduces the prevalence of hypertension, and we know there are many intermediate metabolic phenotypes that are improved by weight loss in older adults, including lipid profile, pulmonary function, and glucose metabolism. So these are some studies that have come out on some things that I think are particularly pertinent to this audience. What's the relationship between caloric restriction and exercise and IL-6? So this is a Pepper Center, a study from our Pepper Center, which was maybe done quite some time ago. And this is a randomized trial in older, overweight, and obese adults with knee osteoarthritis. So that's the target population here. And they were randomized into one of four cells: control group, exercise alone, weight loss through diet, or the combination. And you can see the combination line and the diet and exercise line, the yellow line and the purple line show much larger decreases of IL-6 compared to the exercise or the control group. About 11% reduction in IL-6. Two other studies from our Pepper Center show a 13% and a 24% reduction in IL-6 associated with weight loss. And both of those studies also had exercise interventions which didn't show much in effect. So if you want to reduce the level of inflammatory cytokines in an obese older adult, the weight loss is much more effective than exercise. What about weight loss's effect on gait speed? These are, again, from both some studies from our centers and the literature. I have another two slides that look just like this, but I'll just summarize them for you. The top is also from the ADAPT study, and we can sort of factor out the weight loss effect by taking the weight loss diet-only group minus the control, or the weight loss plus exercise minus the exercise group, and you see an increase of speed in walking speed due to the weight loss of about 0.04 meters per second. Dennis Villarreal's excellent study in more impaired older adults showed a significant increase in the gait speed at a fast speed. There are at least three other studies showing the same thing, where you see about a 0.04 meters per second increase just due to weight loss alone. And Stephanie Studensky's paper from epidemiologic literature shows that a 0.1 meters per second increase in gait speed would reduce total mortality by about 12%. So this would be about maybe a 4%, 5% long-term mortality benefit if the logic holds. And I'll show some data on that in a bit. I'm going to skip that slide. Then the big concern about weight loss and lean mass is, do you make people weaker when they lose weight? Because they're certainly losing lean mass. So this is from Dennis Villarreal's 2011 study. And on the same graph, it's showing the change from baseline, and in the brown, that is the sum of one repetition max between baseline and follow-up across a number of muscle groups. And in the yellow is showing the change in thigh muscle volume by MRI, pre to post. And in the control group, they don't change their strength and they don't change their muscle. In the CR, caloric restriction or diet group, there is a significant 7% decrease in thigh muscle volume, but notice no change in strength whatsoever. In the exercise group, not much change in thigh muscle volume, but a strong increase in strength. That is about the same in the diet plus exercise group, even with a small decrement in muscle mass or muscle volume. So this is curious in a lot of ways. One is, what's going on? Why isn't strength going down when you can measure less muscle? But it's also quite interesting that caloric restriction doesn't make older people weaker, but it makes their muscles more, give them a higher muscle quality. A quality index might be the area or volume divided by the strength, and that seems to improve with weight loss. I'm pleased to tell you about this study of a colleague of mine at Wake, Elaine Kitzman, has just completed a 2x2 randomized clinical trial of aerobic exercise with or without weight loss in older adults with diastolic heart failure with preserved ejection fraction. This is a health condition that is clearly associated with frailty. These are frail patients, but is also strongly associated with obesity. And heart failure of this kind is also something of a poster child for the obesity paradox, that the heavier patients do better and have lower mortality rates than the very thin patients with this condition. And this is just showing that the two groups are different. This group differs with respect to their sarcopenia, certainly. They have much less muscle mass for equivalently weighing or matched older adults, and much more fatty infiltration into their muscles as well. So this recruited 100 patients, mean age of 67, mean BMI of 39, 85% women, which represents the presentation of this clinically. As I mentioned, a 2x2 design. The primary outcome here was peak VO2 attained on treadmill. Co-primary outcome was quality of life. The women or the participants randomized to exercise, had training, supervised training 3 times a week for 20 weeks. The energy reduction was prescribed, and all meals were given to the women, so they were well controlled in what they ate. And they started with a baseline peak VO2 of 14.5, which is very much lower than you'd expect based on the age of the participants. These are the weight loss achieved. You can see each participant by group. So about exercise only did lose a bit of weight, of about 4 kilograms. The diet group closer to 7, and the diet and exercise 10 kilograms. So quite substantial weight loss over this 20-week period. These are the results for the peak VO2. This is percent change from baseline. The control group declined somewhat over this period. The diet and the exercise group both improved significantly, and the benefits of this were additive. So the diet and exercise had the combined benefit of both diet and exercise. And this was also seen in a non-heart failure population in Dennis Villarreal's study. So very strong results. Importantly, the quality of life results are shown here. The first is the Minnesota Living with Heart Failure questionnaire, and down is good in this point. There's a Kansas City myopathy questionnaire, which is the B, and up is good. The change in the SF-36, up is good, and the New York Heart class. And in all cases, quality of life is improved, but most in those losing weight, more so than those with exercise. So in terms of patient-centered outcome, although we're people coming from an exercise physiology tradition are very attuned to the VO2, at least from the quality of life of these patients, the weight loss was very important in that as well. And so this is the correlations of the change in body mass and the change in peak VO2. A is the total mass, and the people who lost the most gained the most peak VO2. The fat mass is shown next to it, a very strong relationship. C is very interesting because while the ones who lost the most fat improved the most VO2, the ones who lost the least lean also had an increased VO2. So it's not just fat and not just lean, both are contributing. The ability to retain lean along with the ability to preferentially lose fat, both combined here to improve function in this impaired population. So if we look then about what we know about what weight loss does to older people with respect to the frailty dimensions as laid out by the by Linda Fried's work, exhaustion, I have plus question mark. No one's really looked at this exactly, but you'd think if VO2 max went up, that would be something having to do with exhaustion, at least exercise fatigability. And many of those quality of life questionnaires that I showed you have exhaustion and fatigue questions in them, but I can't tell you whether those were the questions that changed in endorsement pre and post. How about inactivity? I have minus question mark. These were all sedentary people in Delane's trial, and most people who are enrolled in these studies are sedentary. And people aren't really tracking what kinds of physical activity they do outside the setting of the trial. But what has been often seen or reported often in other situations is that people who are in caloric deficit or not are losing weight tend to adapt by not moving around as much in their life. So unclear what's going on here. Shrinking is not fair, because you're trying to make people lose 5% of their weight or more in a short period of time. That's the whole point. So you can't really use that criteria here to evaluate the impact of weight loss. Trial intervention on frailty. Gait speed reliably increases, and strength, no change, but muscle quality improves. So for sarcopenia, weight loss certainly affects the lean mass component, but in these definitions that include both lean and function, the function seems to improve even though the lean mass declines. So I just want to show you this really quickly because I don't think anyone knows this. We did a study a while back where we used CT to image a bunch of fat compartments in the body because we were sort of curious if test the assumption that if you lost fat, you'd lose it the same amount everywhere. And so these are 44 men who lost on average 6.5% of their body weight, 13.9% of their fat mass, and then we look at pericardial fat, thigh intramuscular fat, thigh subcutaneous fat, abdominal visceral fat, abdominal subcutaneous fat, and abdominal intermuscular fat. So you can see that there is some variation in the percent reduction of fat depots. We went on to look at the correlation of change and change between depots, and the upper extremity subcutaneous and lower extremity subcutaneous highly correlated change, and the other strongest correlation, interestingly, was in the change between abdominal visceral fat and pericardial fat. And so, but others were about on the order you'd expect from an overall weight loss effect. Here's the same data for women. Less fat mass loss percentage, those same absolute percentage weight loss, more pericardial fat, and preferential loss of abdominal visceral fat as well. And that pattern of correlations I just described for men was true for women as well. What about death? We know that, as I said, an older person who loses weight for no reason may not be long for this world. What about trial participants who lost weight on purpose? And we recently published this meta-analysis of there were 15 studies that would have been relevant. 13 had mortality data. And when you add it all up, you see that, in fact, the people randomized to the arm with weight loss had, on average, a long-term mortality deficit of about 15%. So this is good. I was worried when we set out to do this. I would have been quite satisfied with a completely null result. I didn't think there'd be excess mortality. I didn't really think there'd be a reduction, so I'm a bit surprised to see this benefit in the long term. Okay. Lastly, and very briefly, would minimizing muscle mass loss during weight loss be of functional benefit? And just to point out, this is doable. This is a pilot we did a number of years ago where we had women losing either with just a straight caloric reduction diet. Those are the ones in purple, and the ones in blue had extra protein. And the payoff of this was that the percentage of total mass lost as lean was only 15.7% for women on taking more protein in with their meal versus almost 40% loss as lean in women who had dropped all their calories from all sources equivalently. So yes, you can manipulate the composition of the fat, the body composition comes off by, one, paying attention to protein, another is to pair with resistance training. So these are from our Optima study, at least in men, pairing resistance training with weight loss can lead to a substantial reduction in the amount of lean mass lost. Whether this has knock-on effects for long-term benefits and function has yet to be demonstrated. So, in summary, obesity is a strong driver of frailty and functional impairment, and intentional weight loss improves function despite losses of skeletal muscle mass. We can blunt that. Whether that's important or not is yet to be demonstrated. But most importantly, I think fat and muscle and function are intimately intertwined. And we tend to see from a certain tradition people just as big muscles moving around, and certainly that's what moves. But there seems to be some kind of partitioning between fat and lean that seems also to be important, because we've seen here, for example, the myostatin inhibitors, they gain muscle, but they lose intermuscular fat. And there are other animal models that suggest there's some ability to partition energy into which compartment, and that may be important in and of itself. And I'm going to skip this, but I got to quote Shakespeare, "Thou seest I have more flesh than another man, therefore more frailty." And I'm going to make a quick plea, or this is a very international conference, just remind you all that the International Congress on Gerontology and Geriatrics is next summer in San Francisco. Thank you.